we'll have a 15-second gap. So welcome everybody to the SHSC Council of Governors meeting on Tuesday the 15th of February 2022. So welcome to everybody, and welcome to those who are joining us via the live streaming. We're very grateful that you're taking the time to show some interest in our Council of Governors, and we're very welcome to join us. So if we could please move to item 1, which is the welcome and apologies. And I know we've got apologies from Brendan. Amber or Frankie, if we could just have the other apologies, please.
Yes, we have apologies from James Barlow, Liz Friend, Steve Ayres, although I think I've seen Steve on this call. Oh no, sorry. Sue Rowe and Bradley Wass.
Thank you very much. If we can move to item 2, which is the declarations of interest. If anybody's got anything where they need to declare any interest with any item on the agenda, please do so. And remove yourself from discussions on that item. If there are any changes to your declaration at any time, if you could just let Amber know, we will update the list. Thank you. Yinka?
Thank you, Chair. I think I will have to leave at one point in the agenda, won't I?
Yes, thank you. Yes, you will, Yinka. Thank you very much. Thank you for prompting me. Yes, that's for item number 7. Yes, if you wouldn't mind. And actually, Amber, if we could let Yinka know, or somebody let Yinka know when we finish that item, then she could rejoin if she so wishes. That would be great. We'll do that, Yinka. Thank you. Adam?
Thanks, Chair. It's not really, I don't think I actually want a full declaration, but I am co-chairing the programme, the Learning Disability Programme Board, and I think it's under back to good agendas, but it's not like a full declaration, but I thought I'd just raise it now. Okay, is there any item that you think it was relevant to, Adam? It could be the back to good continuing improvement, but it's not a full one. It's just the to let you know that I'm co-chairing some parts of the programme boards. Thank you, Adam. I always think you're quite right, Adam, to err on the side of caution with these things rather than not. So we'll record it anyway, Adam. Thank you very much for that. OK, we could please move into minutes of the meeting held on the 14th of December. Are there any points of accuracy? No. Can we take those as a true record? Yes, thank you. We will do so. Are there any other matters arising that are not on the action log? Yinka?
Apologies, Chair. I don't think I was present at the meeting on the 14th of December.
Thank you, Yinka. We'll remove you. See, we obviously thought you were with us, so there we are. So thank you very much for that. Sorry about that. OK, thank you. We usually miss people off rather than add them in, don't we, rather than the other way around. OK, thank you. So if we can move to item 4, which is the actions, matters arising and actions log, please. Any questions on this? No? Thank you. Well, if we could please move then to item 5, which is my chair's report. Well, it's certainly been a busy time since we last met in December, and this is obviously our first Council of Governors of the year, the new year, although it seems quite a while since it was Christmas and New Year, I have to say. So since the last Council of Governors, like many of the board, carried on with my visits to services and our teams, and quite a lot of us had the privilege of being able to visit a lot of teams before Christmas and deliver hampers as a small way of saying thank you very much for everything that they've been doing. And I've been very fortunate on some of my visits, and particularly last week when I visited Encliffe Ward, to be able to speak to quite a few patients and service users as well. So it's been really good to be able to hear from them as to how things are. So just a bit of a board update. We are recruiting 2 new non-executive directors, and I won't go into detail about that because we've got a separate item on the agenda about that. I'd like to just extend my congratulations to Pat Keeling, who's been appointed our Substantive Director of Strategy, and Pat will be with us later on the agenda. So congratulations to her. Delighted to have her join the board on a substantive basis. Just in terms of board development, we do carry on with our board development programme, and we had a session in December on equality and diversity, leading into another session coming up shortly. So we do very much have a board development programme, just as the council has it. So external meetings have continued in quite a number, so regional, national and local meetings. I've had meetings with the NHS Improvement Regional Director. I've attended Health and Wellbeing Board, and I've had some really good meetings with chairs of other trusts, including R-, Swift, the Children's Trust and the Teaching Trust, all with a view to exploring working together, improving partnerships and relations, all to help us all work closer together in a really good way, positive way. The Healthcare Partnership has had various chairs meetings since I last spoke to you, and Jan and I attended the Shadow Alliance meeting last week. So there's lots going on, and we are going to be having another session with the governors with regards to some of the partnerships that we're involved in as a trust coming up in future months. I also have had the opportunity to go to Flourish last week, and it was great to meet the Chair and Chief Exec of Flourish and explore our relationship with Flourish and all the work that we do with them. So just on to a few governor sort of updates really. On the agenda you'll see, and you'll have got it in your papers, we have introduced, and thanks to Amber for doing this for me, a governor calendar, and you'll have also got various emails from me and for Amber. So this is all about us giving you opportunities as governors to give feedback from yourselves, your families, your constituents and the public on our services, and to also help influence the strategy and priorities and work with us to improve as we go forward. So we've already had our Raising Profile of Carers session, which I was lucky enough to attend, and some of you also attended. And other opportunities have included the Improving Service User Engagement and Experience workshops and the Human Rights workshops. There will be others. We're going to continue to do this. And if you've got anything particular that you'd like to get involved with, please just let myself or Amber know, and we'd be delighted to do so. So you will have also seen that we're introducing some drop-in or no agenda meetings with myself, and this is in response to conversations with various governors, and we're going to do this via constituents groups to start with. So for example, staff governors or public governors or service users, and we'll see how that goes, and we'll just adapt it to what works best for the governors. You should all have the development day of the 16th of March in your diary, and this is something that you'd agreed with I think people organising it before I joined. So these are topics about holding to account and I think strategy and various things. So that's now been definitely signed up for the 16th of March. So just as a separate update about governors, we will shortly be putting together our election time table for governors. It's a really big year for governor elections here at SHSC. So I think nearly half the governor seats are up for election this year, including some of you who I'm hoping will re-stand if you're able to do so. So we will be asking for your help in promoting the governor elections and making sure that we get a lot of interest from people and get some really good people to stand as governors. And there will be an opportunity to work with the comms team and Amber to work on communications for that and try and get that out as wide as we can to make sure we get some interest. So that will be really good. But as I say, really big year of elections. It's nearly half the Council of Governors seats that will be up for election this year. And just in respect of membership engagement and communication, Holly, who heads up our comms team, has been working with Amber, and we've got a meeting set up with regards to looking at how we can get governors involved in some of that communication with members. So watch this space on that one for now. So just a few more sort of service updates really, and things of that nature. So as you are aware, the CQC visited our acute wards for adult working age and psychiatric intensive care units back in December. And tomorrow they'll be publishing their report. We can't discuss anything about it at the moment because it's embargoed, but a letter will be coming out to you as governors following the meeting. So just keep a lookout for that. And just finally, you'll have also been aware that of the changes planned to the management of mental health social care functions in Sheffield. I'm sure you've read about it in the updates we've been sending out. But this is about the social workers who are seconded from Sheffield City Council to work for us at SHSC, and the council's review indicating they're intending in 2022 to 23 to take on direct management control of those functions. And obviously these people have been working as part of our teams for quite a number of years. So we'll continue to support everybody involved and work closely with the council as a partner to make sure that the changes are as seamless as possible and staff are supported and that service users are not disadvantaged. Just on that, Jan, is there anything you'd like to add particularly about the social care functions?
Only that it is the social care function, so the care management as well as the people. So that there will be quite a lot of things that go back into the council that we previously managed with and alongside the social workers that we were seconded into the organisation. It might just be useful to bring that to life a little bit. So that will include the AMPs, the people who do all the mental health work, who are a discrete team really that work very, very closely with everybody else, but they are a discrete team with a certain type of expertise. And then embedded in our recovery teams and some other teams will be social workers and care support workers and care staff, and some of the care management activity there as well. So it will take a little while for us to understand and unpick what that really means for our service users, for our staff, and for our future relationship and how we manage that in a very positive way.
Thanks, Jan. I can see I've got a question from Scott. Scott?
Yeah, thank you, Chair. I just wondered very briefly, just a little bit of background, how this sort of came about, because it seems to have been announced quite suddenly. The other question I have, and you know, is it too soon to kind of ask, because we are anomalous as a health and social care trust, whether this means we'll have to change our name?
Jan, would you like to respond?
I was going to say, would you like me to respond? Certainly, it's so quick, Scott, that we've had very limited opportunity to discuss this in real detail with board members, although they are aware of it. The first, I think you will be as familiar as I am that this has been talked about off and on for a number of years, that and the Section 75, so the formal agreement, was undone or unpicked a few years ago, certainly before my time. So it was a rolling contract, like a service level agreement. That contract was actually out of date and had been rolled over. So so there was clearly some thinking about that, and I think it's fair to say, and in the publications that the local authority have shared with staff, they say, in view of the things that our challenges ahead, they've looked at pretty much everything in the organisation and believe that for a number of reasons, which includes transformation, change, and the way that they are regulated, particularly by CQC, they would like to take back, their words, control of that function, and will think that it will give them a better line of sight and optimise that whole function. The first we knew of it was on the 27th of January. I have to say, I thought we had more time before it went live, and we've done all sorts of preparations to make sure leaders could brief people. I don't think we realised just how quickly they send out their papers for their public meetings, much sooner than we do. we might want to take a leaf out of their book, I'm not sure, but it gave us a bit less time. But we'll work with them to understand the impacts and opportunities. And we have a board conversation at the end of February plugged in to have a look at those. And just in terms of changing the name, I think we've got as far as you have, Scott, which is, do we have to change our name? So
thanks, Scott, for the question. Great question, and yes, one that we've been asked, some of which we're exploring ourselves, as Jan's articulated. So thanks for that. Mark?
Yeah, I was also going to ask a question with regard to that, but Scott's beaten me to it. I think just a couple of other things. I jumped out of the service user engagement and experience workshop, which was slightly overlaps with this meeting. And I just want to say that it felt really good. And what felt particularly, there was a good range of people, but also what felt strong is clearly the trust has appointed some new people to start to pick up on this, and it felt there was a sort of honest recognition that there's plenty to do, but nonetheless it felt energetic and strong. So I just wanted to reflect that back, and then just to say you made me slightly worried, Sharon, saying that there's a development day on the 16th of March. So I've looked at my diary and I don't see anything in there. I'm obviously relying on people setting out diary appointments, so I just wonder whether that could be picked up outside.
Thanks, Mark. I think there's been just a few comments in the chat actually about the diary. So apologies, that hasn't seemed to have gone out, Mark. I think it's because we were canvassing opinions as to which governors could do which dates.
Right.
So I suspect that's why it hasn't gone out. I think Canva's just confirmed it. But in future, what we're hoping to do is try and get a bit, as well as sending the diary invitations out, obviously, as soon as possible, because I know a lot of you are very busy. And we're going to try and keep the calendar up to date so that you can at a glance, I know it's very busy, but look ahead and see what's coming up as well, just in case anything gets missed. Because thank you for your feedback, Mark. That's really good to hear. And we I have to say, I mean, I've only been here 4 months, but I've been really impressed with how much the Trust is investing in a lot of these roles to really move these really important pieces of work onwards. So there's been really good investment in quality and diversity. There's been really good involvement in patient and care experience, and it'll be really exciting, I think, to follow that as it progresses. And we are really keen to give governors the opportunity to reflect and influence priorities of that role. So thanks for attending that as well, Mark. And yes, I think that one of the sessions, there was 2 dates, wasn't there? But one of them does, as you say, slightly over lap with that. And just before I come to Celia, I could just reflect Josie's declaration of interest that she's put in the chat box, as well as a connection with Sheffield City Council. So thank you for that. We'll make sure that's reflected. So, Cecilia?
Sorry, I'm on mute. I do apologise. Yeah. I've not been able to access via the Connect the full information that's been provided to governors and others about what the council is saying once it takes back its staff members. Do you know, are they planning to actually have like a mental health team, a mental health service, to meet the needs of assessment, care management, care planning and all of that?
Do you want me to
Jan?
Respond?
Yes, please, Jan.
They haven't really made any plans. I mean, we obviously do have mental health teams that work across health and care at the moment that provide all of those services, and they will absolutely expect to deliver their statutory functions going by definition. How they will do that in the future and how they want to transform, they haven't set out yet. And I'm sure that they'll work with us to involve and engage to work out how they're going to do that, or what they're going to do, or what they intend to change.
I asked the question because my understanding is that the teams, the adult teams, are generic now. You know what I mean? They're not. And
I think,
and I'm just wondering whether the mental health specialists will simply be added to the general milieu of social workers in the teams, rather than being allowed to be specialists.
I don't know. We don't know. However, what I would say is that it is one of the concerns for that staff group, or some of them, not all of them actually, but some of them. And some of I've spoken to many of our staff since this has happened, not all of them, and Scott may have other intelligence. Like us, they're thinking, okay, there's some opportunities here. It will solve some niggly issues, I think, for some of them. They believe that some of them will believe that they perhaps get a bit more professional focus as well. And others are quite anxious. So there's quite a spread of views about what this might hold for the future. But they haven't, the local authority haven't set out. In fact, they've been very careful to say that their intention is to bring it back in and then work with us. Scott, you've made a comment about the health and care bill, I think, in terms of moving forward, in terms of integration. It does seem to sit out of kilter with that, but that doesn't stop us working in partnership, does it? We don't have to have a contract or a formal relationship to work closely together. And I don't understand how we could unstitch those teams in the near future, because they're so integrated. It's a really, at the point of care, it's a really, really good example of integration.
Thanks, Jan. That's really helpful. Thanks for your questions, Celia. Adam?
Thanks, Chair. Building on what Celia and Scott were saying, a lot. It's happened before within the Learning Disability Service. They took the social work out of that service as well and put it into localities. My question is especially ones with severe mental illness and people with learning disabilities, a lot of them are going to be scared, and a lot of them are going to be wondering what the hell. And same with staff, how can we make sure it's not just the staff are aware of what's going on, it's the same issues as well. A lot of them are going to be, without changes, they're going to be, especially with all the uphill bill at the moment, and they're going to be scared and worried what's going on with the care packages and things like that. So how can we make sure that lot of are aware of what's going on as well? Thank you.
It's a great and a very important point, Adam, and I know it's something we'll be picking up at our board next week when we discuss it. And I think it's just something to say that, Adam, that I think it's got to be absolutely at the centre of all the discussions, and I'm sure it will be, but I think that just needs to be worked through. But absolutely great point, and yeah, absolutely. I think Jan's right. I think there's just a lot of work to do, and I don't think we have a lot of detail at the moment. But absolutely, Adam, that's right at the heart of everything, isn't it? So we'll be picking that up as part of our discussions next week, I can assure you. Thank you very much. Dave?
Yeah, just to add in there, really, following on from Adam and other people's, very concerned about what seems like a real retrograde step when we're talking about wider integration of health and social care. Why are you taking people out of there? And I'd only sort of give the experience of probably going back 4 or 5 years ago now, when they disbanded a reasonably successful specialist learning disability social work team and put them in localities. And since then, the service to adults with a learning disability from that social work now generic cohort has never been the same again, to a point now they're looking to re-establish, hopefully, specialist teams back in the local authority. So I hope that this is an indication that they're going to move the staff who've been working really, really well with the trust for many years in that social work function into a specialist mental health team within the local authority. However, I share my concerns if that isn't the case, because it's going to significantly affect service users and the continuity of care.
Thanks, Dave. And I think that echoes some of what was raised before as well. So thank you for that. Nicola?
Really, to echo what Adam and Dave have said, I think there are substantial risks, even if everything looks like it's all right in the perception of service users in those kind of areas. Unrelated to healthcare, in my day job, I'm a trade union rep, and we had an extensive TUPE last year, and just thinking about the kind of questions and concerns that we had from people in that setting, you're going to have all that from the staff side, plus you're going to have a similar but different, because they're going to be concerned about their care packages, set of concerns from service users who are impacted or who think they might be impacted.
Thank you. Jan, do you want to just perhaps clarify the status of the staff, you know, in terms of 2P, etc.?
Yeah, what I was going to say, we will work really carefully and closely in partnership with the local authority, but the local authority are leading on this. They still employ the social care staff. They are seconded on a contract. We also have up to a year of contract left. So while I think they'd like to do that a bit quicker, it does give the opportunity to think all the things that you've raised and all the questions we've asked ourselves, to think that through. They are very clear that this is to improve and enhance the experience of the service user. And we work closely with them to make sure that the quality impact assessments are done around that. And they are very clear that they also have some challenging financial problems, and they have some very different ways that they need to be, they're going to be monitored, if you like, in the future. So there's all sorts of reasons why they might want to get it closer. And remember that they've got a relatively new Director of Adult Social Care who I might be thinking about these things if I was in a leadership role, might want to get close. There are other ways of doing it, but this is one way. And also, they may have been a bit nervous about our quality issues over the last few years that could have led them to believe that perhaps there's a different way of doing this that might strengthen the quality of service. So there's all sorts of things at play here. But we must stay sighted on service users and the care of our staff as we do this. But they won't be 2P'd because they are the vast majority of them. We do have social care staff with NHS contracts, and we do have some mental health professionals who are have got NHS contracts, and are nurses actually. And that won't change for them. So there won't be any 2P, but the local authority will be leading this change and any consultation that goes with that.
Thanks, Jan. Thanks, Nicola, for your comments and question. Okay. Is there anything on anything else? No, thank you very much for that. Thank you. If we could move on then, I think Ben's not, oh, Julie, sorry, I missed your hand.
Sorry, I was late getting to the meeting and then late putting my hand up, unfortunately. Can I just clarify, Jan, that there's definitely no 2P of our own staff back to Sheffield City Council?
I'm not going to say that's absolutely factually correct, Julie, but I've got no reason to believe that we are 2Ping anybody, or why we would be. But okay. I you know, let's make sure. Julie, we've only known for a week, so we need to go through all of that. But I can't see any reason why we would be 2Ping people over.
Thank you.
Thank you. Okay, if we could then move on. So Ben, as we've heard, is still getting to headquarters, I think, to access the IT. So if we could just leave discussion about the governor's story for now, because Ben's very kindly agreed to do that. And if we could move on to item number 7. So Yinka, if you wouldn't mind just leaving us temporarily for this item, please. So Susan, if you could introduce this, please.
Thank you, Chair. Yes, I can see that Yinka has now left the meeting. So we have identified an administrative error in remuneration for Yinka, which is right from when she was appointed in June 2021. We took this to the Nominations and Remuneration Committee. There has been national guidance that's been issued that was designed to align remuneration for all non-executive directors to a single base rate of £13,000 a year. And you can see in the paper that Yinka's been paid £12,688 per year. So the Nomination and Remuneration Committee discussed this in detail and approved the recommendation to this meeting for approval of the amendment of Yinka's remuneration to £13,000 a year, and also backdated from the date that she started as a non-executive director. So I'm asking for the approval of the Council of Governors. Thank you.
Thank you, Susan. Does anybody on the Nominations Committee want to add anything to that before I take questions? No, thank you. Any questions from anybody? Are we happy to approve it, Governors? Anybody not happy to approve? That's great. Thank you very much for that. We'll make sure that that is sorted out. Thank you very much for that. If somebody could let Yinka know she can rejoin, that would be, I'd be very grateful. Thank you. So if we could please move on to item 8, which is the winter plan and COVID-19 recovery, Richard.
Thank you very much, everybody. I hope you've got the slide pack. I wasn't planning to share it in detail, but I'd rather think it'd be better to talk through some of the key messages and then allow some time for discussion. So obviously we all know where we are with Omicron. It's certainly presented challenges over December and into January, which did impact on services, but thankfully we managed services throughout that period and all services have remained open. But there were periods when safer staffing, there were a few when it couldn't always be met. Again, as throughout the pandemic, although there have been some outbreaks on wards, our arrangements have taken place to support admission where required. So I think really that I guess the message is that it's more now, it's really now about managing the situation forward, and I think concentrating on the challenges we're going to have for the next year. I also think it's a useful time to reflect on some of the things that we've learned during the pandemic, some of the new ways of working which have been successful, but also some of the things that we might want to bring back again. And I think most of the things that I want to highlight are things that we have discussed before. So we've really grouped those under a number of headings. The first one is access and waiting times. So we've still got challenges across several of our services in respect to numbers of people waiting or the lengths of waits. People still have issues, in some cases, accessing services, and there are still stories in the media, and there was one earlier today on the You and Yours programme about people who, for whatever reason, feel they're having difficulties accessing services. Some of this isn't necessarily due to COVID, some of it predates, but nevertheless, I think we need to be cognizant of the fact that there certainly are ongoing issues. Where there's a particular issues, which we now are in areas like the single point of access, we've got what we call recovery plans in the jargon, which each of the key board subcommittees reviews on a regular basis. So, for example, next month, our Finance Committee and the Quality Committee will look at the latest recovery plans for those services and what we're doing and how we're managing those. Some of them we've definitely seen improvements in, but other things, you've got long-standing issues, particularly about staff recruitment, which make it difficult to achieve the improvements that we all want to see. I think generally, in terms of the service demands that we're seeing, most services are now seeing demand levels that are similar to what we saw pre-COVID, but it's things like the crisis service where they're seeing sustained increase in demand. We are, again, subject to staffing. We're expanding a number of these services to try to cope with demand. And of course, we've got the whole issue of how much unmet need there is, what has happened, and I'll come back to that at the end. Set against that, the sort of traditional winter demands have actually been lower. So things like, obviously, our acute colleagues, things like flu haven't really happened. But we certainly haven't seen a particular winter demand. It's much more about COVID. I won't say one of the other things to report on is vaccinations. Obviously, you'll be aware we've managed to, with our staff support, vaccinate a very high percentage of our staffing, and I think that's been a huge success. We worked really hard with people to implement the vaccination as a condition of deployment guidance that came out, and our teams have done really well on that. Speaking personally, I think, as you'll be aware, government ministers reversed that decision very recently, and I know I was on a call with other trust leaders across the country, and I know there's been quite a lot of frustration in the NHS about how that was communicated. In a sense, you know, it's created issues for the staff who put a lot of effort into that. But that's the position we're in now. But I think it's really good that we've got a high level of vaccination. Obviously, COVID created workforce gaps during December and January with people absent due to COVID. I think the other thing to reflect on is that for many of us, you know, for all of us, but for our staff, we've had 21 months of pandemic and recovery now. Staff across the NHS generally have definitely, you know, we've had to respond in a way that's unprecedented in the history of the NHS, probably. And, you know, it has been a huge success in terms of how the NHS has used the opportunity to change services and to meet people's needs in a pandemic. There's no doubt it's taken a toll in terms of long-term impact on people. Some people will leave the service, some people may want to join, but I think we have to go on recognising that. Within the Trust, we're trying to improve the offer that we make to our staff. For example, we just created and issued a staff wellbeing handbook, which brings together quite a lot of the guidance. But, you know, it's always important that we remember that. So just the last bit to emphasise really are on where we are for the rest of the year. We're grappling. What we think is likely to happen is that next year's financial settlement for the NHS generally will be more challenging. I.e. the Treasury will want to try to claw back some of the money that's been spent on services during the pandemic. That's been negotiated by government still as we speak. We've finally received the financial guidance for next year, I think very, very recently, which makes it very difficult to financially plan and to put pressure on our finance team. But I think the public expectation is that services will be able to increase and see more people and recover some of the backlogs. But the issue for the NHS will continue to be, do we have the funding to do it? But even more importantly, perhaps for us, have we got the workforce? Because we're currently not able to spend all the money that we get because we have high vacancy rates, and of the money we have, we do spend significant amounts on out of area treatments for some patients where we are, for example, closing wards for the necessary upgrades, and on agency staff. So we'd like to do less of those things, but it all depends on workforce planning. And we, as you'll have read in the press, the NHS doesn't have a comprehensive, coherent workforce plan at the moment. But we've produced our first draft annual operational plan. That's going to be discussed in the subcommittees and in the board meeting this month. So I think that's something that I'm sure you'd like to have sight of. Subsequent meetings, because I think it's very important. The key messages for that are we must continue to review how services deliver on our strategy and on the NHS long-term plan, which will probably have to be revised actually because it's now significantly out of date because it was written before the pandemic. We need to do everything we can to develop and expand the workforce and the pipeline into that, and improve our succession planning, and work closely with partner services to develop integrated care, which is interesting in view of the discussion we just had. We do have issues about staff turnover, and we've got to do everything we can to try to reduce those. We think that demand for services will continue to increase in the near future, and that we're trying to expand services to cope with that, but there are real challenges there. And I think the last thing to highlight, and the operational plan does highlight this, is that the systemic inequality that does exist in the country, particularly certainly in a city like Sheffield, has been exposed even more by COVID. We think the economic downturn, if there is such a thing post-COVID, will impact on a number of issues in the city. We can see that obviously with the pressures on the local authority are huge next year, and that will have an impact, I think. And it will disproportionately affect socially disadvantaged and BAME communities. So we think we have an important role to help that debate, to do what we can, to continue to raise the profile, and to provide the best quality services we can. So that's in a sense where we are now and what we're looking at in terms of our operational plan. I doubt any of that is sort of new to you, but I think we're trying to bring it into focus. So I'm very happy to answer questions. I can see, I think I'll just get my list correct. I think Scott was first, I think.
We'll just take an order, so we've got quite a few hands up, so we'll go.
Yeah, Scott was first. Yeah, I'm just getting my hands up in order. Scott was first again.
Okay. Thanks, Richard. No, it's really, very reassuring to see such joined-up thinking and to see workforce front and centre. But my question is on a slightly different note, and I'm aware that the government, for whatever reasons, has decided that really the pandemic is over, and that there should be no more restrictions and no more isolation. But yet we work in a healthcare organisation. We work with very vulnerable individuals, so people with serious mental illness were experiencing much higher mortality associated with COVID than the general population. We also work in a place where we're reaching into communities where vaccination rates may not be 100%. And I wondered whether we've given any thoughts to how we want to ask our staff to sort of behave in relation to ongoing infection. For instance, mask wearing and isolation and testing. Because there are things that are different about where we work that maybe we may need to do that are out of sync with national policy.
Yeah, absolutely. I will ask Janet to add a comment on that probably. But before I do, I mean, just to say two things really. I think speaking personally, it's very clear the scientific advice is to have a measured move away from restrictions and to continue to understand the virus and be able to monitor it and take sensible precautions. So that's certainly where I encourage anyone to do that's the behaviour we should model. I think the important point to make is we're governed by NHS rules about infection control and about what we do. So, the Prime Minister may well stand up in Parliament and say something, but we are actually governed by what rules we're told to apply. So, as a board, for example, at the moment we're continuing to meet virtually, and we will be having discussions about moving forward, but we will be informed by the professional advice we receive from the exec team, particularly from Beverly and Jan. So rest assured, we won't be. I don't think we'll be changing behaviour rapidly. But Jan, do you have anything more up to date on that?
Broadly, that's absolutely right, Richard, and something that we've worked with all the way along. So there's two or three things. One is non-executive directors have been asking us all the way along, now things have changed, does that change things for us? And actually I've just provided with Sharon some information for their meeting tomorrow on that very subject. So our rules, although the society's rules, if you like, may be brought forward to February from March the 23rd. Ours are still in place until March the 31st, so that all the things that we're doing at the moment, Scott, still stand across the NHS. I think the leadership challenge is helping people to understand that. Now, if I give you an example of another place, a chief executive was talking to me yesterday who said that a member of his staff came into work after being at a concert at the weekend saying, I've just been in the middle of 3,000 people and now you're asking me to wear a mask in an office with one other person. And both our view is, if I was that other one person, I'd really want you to wear a mask if you've been in 3,000 people at the weekend. But it will become more and more of a leadership challenge because of what's happening in society. But that's, you're quite right, that's when we're probably more vulnerable, much more vulnerable than we were in the first lockdown, when we pretty much knew everybody was coming to work and going home. So you have two bubbles really, your family and your work family. So we will keep reviewing that to make sure that we're in line with the guidance, and also that we are listening to people to support leaders and staff to do what is commensurate and all the rest of it. The other thing that we need to pay attention to is risk assessing, particularly our staff when they're going into areas where they may be at risk. If they're vulnerable themselves, we must not stop. We must keep an eye on that. As we have done all the way through the pandemic, and not lose sight of it. And also, we do have a small number, and actually, relatively speaking, it is a small number who aren't vaccinated. So we have to continue those risk assessments. And the same goes for our service users. Many are now vaccinated, and some aren't. So we need to keep risk assessing those as well, in the community or in inpatients. But you're absolutely right. I think so we made a decision, Sharon and I made a decision between ourselves this morning that although we are allowed to meet as a board, as a group, we would have to wear masks all day, which sort of defeats the object of being face to face and seeing facial expressions, etc. And do we really want to run the risk while Omicron and various other variants are still quite high in the community of wiping out the whole board? No, we don't. So those are the sorts of decisions that we're making.
Thank you.
Thank you.
I think Richard and Jan are absolutely right. It's a discussion that keeps cropping up more and more as life outside of the NHS takes a different turn, I think. So I think watch this space for the guidance that may or may not arrive at the end of March, I suspect, Scott. So we'll wait and see. So we've got Terry next, please.
Yes, thank you. I've got two questions, so I don't know if you want one time or both at once.
We'll take them one at a time, Terry. We'll be kind to Richard on this occasion.
Okay. One of them was about access to services. I mean, I know we've already got, quite high demand and unmet need, but I wanted to ask specifically, you mentioned sort of ethnically diverse groups who have historically maybe not had the access to services that other groups have. It might be a question for someone Karen or Jan, but what is actually being done within the trust to address that and to try and improve that access? Are there any sort of strategies underway, for example, is the NEMA involved in what's happening?
Can I say a couple of points, and then I think maybe it would be good just to chip in with Jan. We discuss this on a regular basis as days because we're very conscious of the socio-economic and ethnic diversity in Sheffield. I'm aware that there is a Manchester University going to publish what has been trailed by Dan reporting in NHS generally in terms of access to ethnic minorities later this week. And if you remember, one thing that was the level up green paper, white paper, there's actually an NHS, there's a health component to that that's supposed to be coming out, I believe, next month. So that may well have more information in there, which I think would be very helpful if it did, because that could inform our discussion. We're still we're basically trying, how it ends, but we're trying to develop networks within staff within the trust to increase the visibility and to increase the empowerment that people have, as well as therefore trying to reach different groups and to tailor our services. So I think it's very much work in progress, and we do have specific initiatives, and it will feature in the operational plan as to what more we can do, but also with our staff recruitment. So that's, I think, that's the sort of lead perspective on it. I don't know, Jan, if there's any specific you want to add on it. You're mute, Jan. She knows, yeah. No.
I'm sorry, I'm having real problems with my mute button today, but I did notice that Heather put her hand up and wondered if she wanted to add or respond, or it was something different.
No, it was the response actually. So Terry, the multi-year quality inclusion strategy, which we approved at board recently, which does include reference explicitly to this issue. And you'll see one of the agenda items later is about the quality objectives, one of which is around access to services. So there'll be an opportunity then to ask, of the person who's coming to present that, what's happening. At the moment, a lot of it, we talked about in the quality committee the other day, a lot of it about collecting data to understand, where the issues are in Sheffield in terms of our access issues and what the proportionality of the population and things. But a comment that was made at the quality committee is there comes a point at which you need to stop collecting data and just get on with action, and that's where we're at now, really. So it's definitely on agenda. It's been talked about every month. I would say this is an issue that we are addressing, and it's certainly very high on the agenda.
I'll just add that at our next board meeting, we have, in March actually, our next public board meeting, we have commissioned with a small C a piece of work to look at the activity across the organisation, because we know we're doing lots of things in lots of places. We know that it's one of our priorities to make sure that we think about inequalities as part of our aim, and therefore it should be stitched into all the things that we do. So it's a map really of what we're doing at the moment, and then start to see where the gaps are. But I think it's also a little bit like the green agenda or anything else that's quite a big thing. We've got to make sure that we prioritise, stay focused and make sense of it, because it will never be finished, will it? And Mark flagged that the Race Observatory issued their report yesterday, didn't they, Mark? And said some fairly important things about the challenge faced by the NHS to address this issue as well, which we'll be paying attention to.
Thank you. The other question, again, this might be slightly more for Jan. It was around vaccine mandates, because I'm aware that was withdrawn very, very close to the deadline for first vaccinations. And I also noticed in the media that the NHS in Wales, which didn't have a mandate, was encouraging sort of unvaccinated staff to be able to go and work for them. Have we lost many staff as a result? Have we lost any staff, or enough, a number that might be an issue? Because obviously already there are recruitment issues and a shortage of positions being filled.
It hasn't been withdrawn yet. They've just asked us to pause while they consult, and then, because it's legislation, so they will have to get that reversed. However, they have asked us to pause, and you're quite right, it was a couple of days before. Just in defence of my NHS colleagues in Wales, I don't think they were actively encouraging people to come across the border. I think Daily Mail might be, and people were making their own decisions about going elsewhere, Scotland, Wales or Ireland. But I probably have to defend a little bit NHS Wales, because I don't think they'd actively do that. So I'm not aware that we've lost somebody directly related to the vaccines. I think a couple of people did make choices quite early on to leave because they felt so strongly that they didn't want to work in an environment where they were mandated to have the vaccine. And we didn't know where we would end up, but we had quite small numbers in the end towards that end of date, especially compared to some of our colleagues in other NHS organisations. And I'm really pleased that, you know, the most important thing is that people made the choice with information at their fingertips, and that had always been our policy. So it was really good that we got to that point with the time. The end date's very, very close, and it's been very difficult for those who spent a lot of time and effort working with people to help them understand that full breadth of information. That said, it was worth it, wasn't it? Because so many people have been vaccinated, and all of us are safer because of that.
Thanks. Is that okay, Terry?
Yeah, yes, that's fine. Thank you.
Thank you. Thanks for that, Nicola.
On page 2 of the slide deck, when talking about service recovery, measured levels of face-to-face activities continuing to rise, and around 15% lower than pre-pandemic levels. What are we looking like in overall activity levels?
So I think, as I said in the slide, basically activity levels are at the point where they were pre-COVID, and in some cases are above that. So I think the issue is that in some areas the demand has increased even further than that. In some areas it's actually lower. So some of our acute services, you know, we haven't had the same pressures as we might have expected. So it is a mixed picture. And I'm being a bit cagey because I think the honest truth is we still don't we're not really fully understanding why some things that have happened, and more importantly, where is it now going to settle if we're in, you know, barring further variants emerging, as we probably will at some point. Excuse me, I've got sole charge of a slightly overexcited cockapoo at the moment. So, you know, that is going to settle at a level, and I think that's what we need to work on and understand. But it's clear where the pressures are next year, I think, and that's what we need to focus on trying to do that. It does go hand in hand with, I mentioned those recovery plans. There's quite a lot of service recovery work and service redesign work, which we needed to do anyway. So, for example, Janice highlighted the work with recovery teams and the community teams. So I think, you know, it's winding up the future demand, and the best way of doing things in the future, whether it's virtually for some people, into our service offer. So I think we're moving into that area now.
True, and also, I mean, I noticed you mentioned IMPT maintain high levels of online contact in the service and the services around Waterbrook, the GIC. Quite a lot of stuff has gone online there, and to a greater or lesser degree, some of that does really work.
The other thing I would say is I'm remiss probably not to mention that some of our biggest issues about demand are in some of the specialist services like Sandbag Gender Services, and we raised that very strongly as meds. But fortunately, a lot of that is, you know, we've probably gone as far as we can within the trust in terms of reconfiguring and improving those services.
Some of it in gender is long-standing pre-pandemic. From my own past background as a clinician, although I don't currently actively work in healthcare, it surprises me that some of the ways of working that the gender services, not just Waterbrook, but across the UK prior to these current pilots that we've got elsewhere, have been and have stuck with and I'm slightly loath to maybe describe it as a model of fake fairness at times, where patient-centred care has disappeared in favour of this is what the process says.
Okay.
But I mean, that's a whole creative of words. And
Nicola, just two things from me really. One, you asked about probably a bit more detail, and I think at our last board meeting, this is Richard's sort of kind of summarised, if you like, a much longer report for the Council of Governors. But actually, I can't remember if it was a separate report or if it was a part of it. But we definitely have more detail at the last board meeting if you're interested about across the board about the impact of COVID on demand. So you can certainly access that via the website, or if you can't, Amber can certainly help you with that. That's not a problem. That went to the public board. And in terms of your own experiences, if you would like to be part of our sort of new and renewed and refreshed, sort of feedback and sort of patient and care experience work, we'd be absolutely delighted to have you part of that, because feedback is essential to change things. So just have a think about that. But if you'd like to, just get in touch with me or Amber, and we'll certainly we'll be delighted to work with you there.
I mean, this was fundamentally one of the reasons why I wanted to get involved and become a governor, was to not only represent my interests to some extent, but those of that constituency. And at the risk of it potentially being quite not necessarily marginalised in the way that we might talk about marginalised communities normally, but marginalised in that it's a small service. And general services are a bit of an orphan service because so many of them have sat in mental health. When is it mental health? Is it actually a physical health service? But it's stuck in mental health because historically, because in 1960 whatever, the psychiatrists decided they wanted it, and the endocrinologists said, yeah, whatever.
Yeah, well, thanks for that. As I say, Nicola, experiences like your own are really important to us. So let's have another conversation.
Oh yeah,
absolutely. That'd be fantastic if you wouldn't mind. If you've got the time, we'd really value that. That's great. Thank you. Is that all right? Did Richard answer the rest of your question?
Yeah, that's fine. Yeah.
Okay, great. Thank you. Cecilia, thank you.
Hi. Yes, it's a really simple question, to be honest, and it is about HIAT, and it's the issue about the high levels of online contact, which is great, and hopefully it's very successful. But I was wondering, is it all online? Is there no face-to-face, or is it a mix, or what?
It's a mix, isn't it? Correct me saying.
That's what I'm asking.
Yep, you are correct, Richard.
Yeah.
And it's a choice.
It's a choice. Whose choice? Is it the client's choice?
The client's choice. Yeah. It's a discussion and obviously it's a two-way discussion between the client. During COVID it wasn't much of a choice because for obvious reasons, during the height of COVID. But as we move into a different time, it's a discussion between the client and the practitioner.
I'm sorry to sound sceptical, but from the little bit of information I know, I don't think the clients feel that it's a choice.
I think there are.
I'm not talking about disease.
Well, neither of us can talk for all of them, can we? So, but I'm right. I've seen feedback from clients. There are certain elements that are delivered online. Actually, some of them always were, and more of them are now. So they may have expected a face-to-face, but there's still a conversation to be had if they were expecting something different. So there are a group that will always have online stuff first, and did have before. But yes, you're right, there are some online things, there are some service users who don't necessarily see that as a face-to-face opportunity. There are also lots of service users who prefer non-face-to-face and will engage better. So we just need to make sure that we stay open to helping them access what they need.
Thank you, John.
Thank you. And actually, that was a debate we had at the board as well, wasn't it, last month, about making sure people did have a choice. But because you're right, different people want different things. I mean, I know from previous experience that lots of younger people, for example, who work prefer not having to travel and just be able to connect online, whereas other people, you're quite right, prefer that in-person meeting. So it is about ensuring people have the appropriate choice, absolutely. Adam?
Okay. My background on rest of it is, and it's regarding the COVID recovery and all that, but are we still having a problem with staff burnout and more staff off sick?
Well, I mean, there's two things to say. There's the long-term effects, which vary from person to person and individuals. And some people, you know, I mean, we have a high level of staff turnover, which we've had for some time, and there undoubtedly are other reasons for that. Some which are COVID related, some which relate to the organisation itself and predate COVID and so on. So I think there's a multiplicity of reasons. I think it's quite well documented that some people left the service because of the pressures. Some people, you know, have entered the service because they feel there's a role that they want to perform. I think it's worth saying, and Heather might want to add something, that the whole issue of retention and recruitment is a huge, you know, it's probably our top risk and our top priority. And we're trying to understand more about retention. And as the year rolls on, we can better understand how we can continue to support staff and the staff that we've got and attract in other staff. But you know, we do exit interviews, we do all these sorts of things, but you know, it's a complex, I have to say, it's a complex picture. I don't know whether Heather or Jan want to add anything.
Not really. I think the only thing is that staff sickness levels, you're right, are higher than they've been, but we have asked now for it to be released, split out, you know, for those who are absent due to COVID and those absent for other reasons. So we're getting a bit more sophisticated in our analysis as well, which always helps them with the actions that can be taken. So yeah, it's something which we're trying to address through the last Council of Governors meeting. I talked about all the health and wellbeing offer, because obviously we want to try to prevent burnout as much as possible, support people as much as we can. But it is complex because there's all sorts of things going on that have an impact on that. But certainly retention is an issue that we are concerned about, and we've been asking for more information about that and actions to address it.
Thanks. I think Adam as well, this is something that it's a really good question. It's something that's not unique to us. I was talking to a chair, I did mention in my chair's report how many local chairs of other trusts that I've met with in the last couple of weeks, and I was talking to one of them in particular, and their turnover rate was even higher than ours, and sickness rate about the same. And it does vary, some are lower, some are the same, but I think Jan and I would probably say that from the work that we're starting to do with partners as part of the system and the alliance and things, workforce is one of the things that does crop up as an opportunity to work together, not just as a trust but across a sort of other trust as well. So hopefully as those sort of conversations develop as well, we'll be able to work together to not just have to deal with it by ourselves as a trust, because it is a really difficult thing to do. So but thank you for that. Catherine?
Hi, Thanks, Sharon. I just wanted to go back to Cecilia's point, following from there about IACT and the online provision. And I suppose I wanted some reassurance to make sure that whether people accessing the face-to-face aspect of IACT versus the online aspect of IACT had some equity in terms of that access. So would there be a longer waiting time for people opting for the online, for the face-to-face treatments? And I suppose what I'm wanting is some reassurance that therefore good clinical decisions are sort of made, not just a shorter waiting time to access something online.
I don't have the answer to that question for sure. We can go away and find that. I think so that's the answer. I think in terms of the ARC service generally, I mean, we're very proud of the ARC service, which is, you know, has grown into a very big service, providing a lot of care to a lot of people, and they are seen as one of the more effective services in the country that are giving advice to other people. And I think they're constantly, my impression is that they're constantly looking at what they're doing and trying to refine it so that they can provide the best offer they can. That's not to say that there aren't issues, and there may be some disparities, but I think it's, you know, if you've got any examples, again, I think picking up Sharon's point, it'd be worth, you know, if there's anything we can look at or investigate, I'm sure that would be worth us doing, because, you know, it's as right as we can, but I suspect, I think there probably is an equitable offer for people who actually are clear that they do want face-to-face, but we need to go away and check that. So that thank you.
Yeah, yes, I'd really appreciate that if you could sort of feed something back in just to reassure me that that equity is there and therefore good decisions are being made. Because I think similar to Cecilia, that the feedback that I hear from service users is not of an experience of choice.
Okay, well in that case, that is definitely something we should pick up. Then that's helpful to know.
Thanks.
Thank you. Thanks, Catherine. We'll pick that up and make sure that we respond to the question. Absolutely. Okay, thank you. I'm just aware of time. Have I missed anybody? I don't think I have. So we were due to have a break at 3:40. I know we're slightly behind. I suggest we just have, if we could just have 10 minutes now and then come back, and we'll then start with item number 9, if that's okay. So if you could turn your cameras and you just mute off while you have 10 minutes, and I'll see you back here at 56, please.
Hiya, something's up with the live stream. No, Matt's just pointed out there's an echo on it, but that's because I was playing it on the live speaker.
Okay, welcome back everybody. Hopefully we've got most people back with us. So if we could please move to item 9, which is getting back to good. Heather is very kindly chairing the quality committee, and I have to say doing a great job of it as well. So thank you, Heather, for stepping in. So over to you, Heather.
Yes, hi everybody. So it would have been Sandy doing this report in the past, so you got me this time. So what I'd like to do, I'm going to share my slide deck in a minute. It's just 4 slides, so hopefully it won't be too onerous, but also it helped to prompt me as well in terms of the comments that I wanted to raise with you. For those of you who are new to the Council of Governors, or just as a reminder really, the Back to Good programme is explicitly the programme which addresses issues raised by the CQC in their reports to us. So these reports talk about things that we must do and things that we should do. So what any Back to Good programme update does is not cover the entire remit of all of the quality initiatives and improvement work that's going on at the Trust. It's quite explicitly about the things that the CQC raised and how we're doing against those. So if you could just bear that in mind when I'm talking about it, because there's probably lots of things you're thinking, well, what about this? What about that? You know, there are lots of other things as well, but this is particularly a report to you about how we're doing against those actions that the CQC said we must or should do. So let me just share my screen, if that's okay, and then give me a second. Here we go. Okay, so what we're going to look at here then is just the numbers bit of it and where we are. So we're in year 2 now, and that's because the first set of actions was all about the CQC report, which was given to us in April 2020, and all of those requirements have now been completed. So we're now on to the year 2 requirements, which are drawn from the CQC report received in August 2021. And that CQC inspection was on well-led, so to do with the leadership of the organisation. And it was also about our acute wards, the psychiatric intensive care unit and the older adult service. So it was quite specific. So these actions are particularly focused on what we're doing around those areas. And what the rest of that data says is that basically we're about halfway through where we should be in terms of addressing those actions, so where we would hope to be. So in the right place, we're about halfway through addressing those actions. The last time that Sandy presented this report to you, she talked about requirements that had actually been completed. So what I've done here is just giving you an update really based upon that report that you saw last time. So these are new requirements completed since the last report. So I'll just run through these quickly just to give you a sense of it. So things like the awareness and understanding of the duty of candour, that was something the CQC said we needed to do more on. And indeed, you know, there's been a new policy, there's been training in place for staff so that we are further forward with that now than we were when CQC arrived. The bit that says staffing levels, the way it's phrased there, I thought, well, some people might read that and think, well, that's just not right. It says staffing levels are suitable for services provided. And as we know, as we've been talking about throughout this meeting, we've got issues with staffing levels. But this particularly refers to whether we have safe staffing on the wards. And so that is something which there are lots of actions being done around that. There's been particular reports that are produced now. The shifts on the wards are carefully monitored to make sure that the people who are in place have got the right level of qualification, etc. There's staffing gaps reported and recruitment plan, particularly for those areas. Obviously, there is a recruitment plan for the rest of the organisation as well, the Trust as well, but for this area, it's something that's monitored closely at People Committee as well as the Back to Good Board. So that means that we're in a better place than we were when CQC came last time and told us that we didn't have safe levels of staffing on the ward, or there were too many preceptorships in charge, etc. So we're not in that place anymore. We're in a much better place. There's things to do with ligature anchor points there. Again, it's an issue for us because a lot of getting rid of the ligature anchor points involves estates work, and that has inevitably been caught up in COVID-related issues and access issues, but we have got mitigations in place. And we do know where all the ligature anchor points are, and there is an estates plan to address that. There's been a lot of work done in environments, and we have all single occupancy rooms now on all the wards, and the refurbishment plans are all with the intent of providing therapeutic environments. And for those of you who might know about the switch from Burbage to Dovedale 2, the environment there is already much better, and obviously that will then decamp back again. So there's a whole plan here to make those environments a much more therapeutic place for our service users. We mentioned earlier about the new equality and diversity strategy, so we have been making progress on that. And there is also a new equality and inclusion governance team that sits beneath the People Committee and is working very intensively on the operational implementation of that strategy. And there are some new posts in place as well to help us with this. I was talking to somebody earlier whose responsibility is to look at increasing recruitment from those groups which are not currently represented in the staff, and also to look at things like the issues of no tolerance of racial harassment on the wards and things like that. So there's lots of work that's been done in that area. We've improved access to key information for ward staff that was missing, and we have made improvements in seclusion on the older people's ward. There's been a lot of work to examine what we do about restrictive practice. And indeed, we're looking not to have seclusion areas on a number of wards, and that's something that's come from the staff team rather than being something that's been recommended by senior managers. So there's some very positive news stories around that. And patients involved in treatment and care planning, there's been improvements around that. Quarterly reports to the lived experience group, patient information booklets specific to each ward. That kind of work has definitely seen some advancement. So I know that one of the things that you will be keen to know is, well, how do we know that the quality of care is getting better? So we could just say, yes, we've got a new policy, tick, yes, we've got this new training in place, tick, but what's that actually mean for the quality of care? And so some of the things that we have in order to be able to enable us to do this triangulation are on the screen here, and I'll add some others verbally. So we've already got these new culture and quality visits. So these have just been set up. A pilot's been done at Wainwright Crescent. And what these are effectively is like a sort of internal little mini inspection teams, really, who go along to be able to do a real deep dive into a ward or an area and be able to come up with the staff about some recommendations of things that could be done to improve. So there's a programme of structured visits that are going to take place there. The purple block talks about out-of-area assessment process, because, of course, we're not just responsible for the quality of care of our service users on our wards, but if those service users need to go to another place in order to be able to be cared for various reasons. And we've now got much more rigorous assessment processes going on in terms of that, the quality of care that goes on there. Board visits have been, in real life recently, which has been fantastic. It's given us an opportunity to talk about things which we've heard about in other ways, and that's enabled us then to be able to triangulate and to ask staff about what their experiences of some of the initiatives that have been taking place. More compliance with care standards. There is a new system we've put in place called Tenderable, which is an audit system. It's a tactical level because it's about immediate actions. It's a real life tool about what's actually happening at that time. I mean, it's new, so there's still lots of work sort of bedding it in, but that is something that will help us to know that things are getting better. And also in terms of team performance, there's all the data, much more refined levels of data now that each team gets about their own performance. And that involves key metrics. And also, interestingly, we're working with NHSEI at the moment to agree a process of early risk indicators, because ideally we want to preempt issues that are happening, not always be responding to when we see issues arising in the data. So that would be an interesting piece of work. Then on top of this, of course, we also have, and really sort of encompassing all of this, our service user feedback. It is part of the culture and quality visits. It is part of board visits, and because as Sharon said earlier, she's been talking to people on the wards, etc., when she went to a visit to Encliffe the other day. So there are lots of ways in which we can get this feedback. And so that's also something that helps us to understand whether the quality of care is getting better. And I'd also like to reflect on what Mark said right at the beginning of this meeting, because the new strategy on service user engagement and also employment of those people with lived experience is enabling us to get feedback right at the beginning of processes when we start to actually implement changes, so that front end improvement and feedback, not just always asking, well, how was it for you, but what's it been like and how can we use that in the development of our new strategy? So, for example, the new clinical and social care strategy, that we had service users involved in that from the start. So that's just a few things. My last slide, when I asked the team, well, which 2 areas do you think you're particularly concerned about? They highlighted these 2. I mean, there are lots of other issues. We talked already about massive issues to recruitment generally, but that's at a kind of trust-wide level. But in terms of these particular CQC things that the team are following through, they have indicated that they are concerned about incidents being reviewed in 5 days of reporting. So we've done a lot of work on incident reviewing, and the vast majority of them, there's no backlog anymore. All that's been sorted. In fact, we've had an internal audit, which has given us lots of assurance that our incident reporting system and feedback and reviewing, etc., is good. But there's this thing about 5 days, is it done in a timely way? And that needs constant monitoring. We're not fully assured about that yet. And also the supervision rates on the acute wards. There have been lots of challenges in terms of staffing, and that has had an impact on supervision. Although I did hear today that Stanish ward has now hit their target. So, the things are improving literally day by day. And of course, what is reflecting something, I'll just come out of this now. Sorry, let me just share my screen. Reflecting something that Sharon said earlier, of course, we are expecting our next CQC report tomorrow. And so that will mean that we can add more actions, and that the next Back to Good report will include some new actions that have been raised as a result of what we're hearing from CQC. So that's a very quick sort of waltz through what's been happening in terms of that Back to Good programme. And obviously, I'm very happy to answer any questions if I can about any of the detail that I've shared with you.
Thanks, Heather, and I think your context setting was really useful as well, so thank you for that. So we've got a number of hands up, so we've got Cecilia first, please.
Hi, thank you for that, Heather. I was on the board a few years ago, I mean, we're talking a few years ago, and one of the targets was to bring people back into the city rather than provide services for people out of the city. And yet we seem out of the city seems now to be one of the things that, I don't know, maybe we failed in our efforts to bring people, our service users back in, as opposed to having them as outliers in other agencies or the other authorities. If you could give me a quick scope of what our position is in relation to seeking to bring people back or not, as is the policy.
Yeah, no, thanks for raising that. It is our aspiration for people to be cared for as close to home as possible. There are some reasons why there's specialist units when it's appropriate for somebody to be out of area. And actually, when we get our reports, it does say the numbers who are appropriately placed out of area as well as the others, because there are sometimes some specialist services which are at a distance, so that is accepted. But on the whole, we do, our aspiration, we monitor it all the time, Cecilia, because we monitor the numbers of days that people are out of area, we monitor the numbers of people, and our aspiration is to have as many people at as close to the point of their home as possible. It's just sometimes there aren't beds available, and so we have to look outside for solutions to that.
Are we experiencing a particularly difficult episode in provision within our own city then? Is that any different from what it ever was?
Perhaps I could add a bit of...
Richard, do you want to come in? Because I was going to add something, but you go ahead.
Cecilia, the Trust was proud for many, many years to have not made any out-of-area placements, and that was a cornerstone of our strategy. And that is still our intention. The big thing that's happened is that following the CQC inspection 2 years ago, we obviously had to make a whole raft of big changes, physical changes to the wards, as you'll be aware, to reduce ligature points and a lot of other things. And that we simply haven't been able to make those changes without closing some of the beds and closing some of the wards for periods. And therefore, that's where the big issues arisen about having to place people outside our service. And indeed, we've negotiated a contract to do that with one or two preferred providers. And we're going to have to do that through this year and into the early on in next year until we've completed all those ward upgrades. But it's very much, for that, it's very much a one-off, you know, it's a time-limited thing that we wouldn't normally be planning to do. So that is the big increase, and the Finance Committee reviews that regularly, and we'll have a review about it next March. But, you know, I wouldn't want you to think that we moved away, you know, from the previous policy in any significant way.
Jan, was it on this point or was it a different one?
Thank you.
It was this point. I was going to gather together. There are a number of reasons why we've got out of area. We've got one of the lowest bed bases in, or certainly in the North East and Yorkshire. And there's good and bad in that. I'm not judging on that. Secondly, as Richard said, we have closed some beds to do the work, and they keep moving, so there's a complement of beds, but we have replaced those with beds, but they are out of area. And then thirdly, 36% of our beds are occupied by people who could be in a different place at the moment, so they're delays. And there's a range of reasons for those delays as well. So we are over quite a long period of time using 100% of our capacity, which actually is too much. We should be around 92 to 95 for real effectiveness. So they're working too hard. And so there's a number of reasons. And while we've got all of those variables in place, it's very hard to know if we've got the right complement. We've also got work to do around our community teams and more work to do actually around our crisis pathway to make sure they all work, and where a bed is the best option for a service user, that's available. So all of those pieces of the jigsaw play in, as the non-executives have talked about, if we are to work through, if we've got the right number of beds, if we've got the right services around those beds, and we need the help of our partners to make sure that we can keep people out of hospital if they don't need to be in hospital, and we can get them out in a timely way when it's time for them to go home.
Thanks,
so
John.
it's multifactorial, basically, Cecilia.
Thanks, Cecilia. And can I just add to that? Okay, yeah, on one of the wards I was on visiting the other day, that was absolutely, you know, there were a number of people who ideally would be somewhere else, but it was very complex, the situation. So it was having an effect on the flow of the beds. But it is something that we carefully discuss and monitor every month as part of our reporting. But it's a really important issue. Scott?
Yeah, I'm going to be quite challenging, but then you'd probably be sort of disappointed if I wasn't. I'll make a few general points. One general point is, yes, I know Back to Good is about CQC, but actually we shouldn't be introducing Back to Good by saying we're only going to talk about the CQC requirements, because we can meet CQC requirements and still not be good. So I think we've got to kind of stop talking about just CQC. The second thing I would ask is, what do we do when we know genuinely that things that we think we're trying to improve are not improving? Because there are definitely, and it is complex, and there are mitigating circumstances, and there's all sorts of reasons why things aren't sort of happening, but there are bits of our trust and bits of the trust where I work, where things have been bad and are arguably getting worse, actually, in terms of patient experience and the mismatch between supply and demand. So one point of assurance I would sort of like to see from the board, it's really good. All those things that you've mentioned that are happening are all really good, including the board visits. But one thing that we're still not doing is checking in after a board visit that the feedback that you've given has reached everyone, and also that the feedback feels valid. when we do qualitative research, often one method is that we check in with people who participate in the research with our transcripts and our interpretation to check that they think that we fairly represented what they've told us. I don't see that happening in the board visits, actually, and I would like to ask the non-execs to actually check in after those board visits to make sure that the people who took part feel that they've been properly represented, that their views have been interpreted correctly. I think that might go some way towards helping to move us forward in these really difficult areas.
Okay, thanks, Scott. Can I take both points then? So the first one, absolutely agree with what you said about CQC. I made the point because I didn't want people to think that that this is all we're doing. Okay, so I was actually I think supporting what you were saying, that this is only a part of what we're doing really here, and a complete overview of everything that's happening, would have to be chopped up, I think, into different areas really. So that might be in future what the governing body wanted, something slightly different. But I did want to highlight that this isn't everything. Okay, so that was the second point. I think we do some of this already, actually, because in fact, I've just done a visit and I've just seen the feedback which has been sent to the team to say to them, this is what we think you said to us. Is this right? Okay, so that literally this morning I've just checked it in order to do that. It could be that we need to do that more rigorously if you don't have the sense that that's happening. So I'll definitely take that on board and have a think about how we can close the loop a bit more on that one. But I can assure you, we don't just write it up and then never say, we do that thing where we send it back and say, this is what we heard. Is this right? Okay, so I'll try a bit harder, Scott. That's the thing, isn't it? And I'll certainly take on board what you said, because if that's not being heard or seen, then we need to make it more explicit.
Oh, okay, thank you for that. It certainly, all I can do is, reflect back on my own experience and sort of see if the things that I experience are tallying with the things that you're telling me. And I have to say that they don't.
Okay, so, well, that's useful feedback, and it's only by getting that feedback, Scott, that we can respond, really. So it's really helpful. So there's definitely something there to work on. But I think it's a wider issue. It's not just to do with board visits, is it? It's the whole thing about, and this is the big question. It's the big assurance question, isn't it? It's the so what question. It's, well, so is this having impact? Are we seeing change? How do we measure change? How do we know that change is happening? And, that's the thing that we're trying to get better at and better at all the time. So I can assure you that's not something that we don't kind of cognitively understand, but it's something that we, it's quite hard sometimes to be able to really get to the bottom of impact.
No, but I do think there's a difference between talking about assurance and providing it. And historically, and I've been here for 4 or 5 years now, historically, when things were going really wrong, we heard a lot of talk about assurance. We moved into a phase where we were getting more assurance. I have to feed back today that we're going back to talking about the theory of assurance, not the actual assurance. I'm just feeding that back, and I don't mean it to be taken the wrong way, but talking about what we should do and we might do is not the same as providing the assurance.
Okay, I'll take that, Scott, and I'll think about how we express it, because I think we have more robust assurance than we've ever had. Okay. So it's the way I've communicated it. So I will think about that one.
Thank you, Heather. Thank you.
To be fair, Heather, I think it was probably worthy of another conversation, because the last thing we want to do, Scott, is be defensive and not hear it and not react to it. We don't want to do that. But similarly, I'm not sure I heard it the same way, and I'm not sure what you've said reflects what I've seen all of since I've been here either. But I tell you what would be useful, Scott, is if you've got even small specific examples, for example, your feedback loop one, which we could easily do something about if that's not working properly, then we'd appreciate some specifics, because we can absolutely do something about those. But let's have a conversation outside, because I accept the challenge and I don't want to be defensive about it, but I'm not sure it's entirely reflects what I've seen since I've been here, I have to say. But Jan?
Just a couple of additions, really. Remind non-executive colleagues that we have discussed we've not quite closed the loops on some of the visits we've done, in a way that is effective as it should be. So we've got more, it's quite hard to do, but what we do is revisit in a cycle to make sure that we sort of close that loop. But we have talked about how do you close those loops once you've heard, seen, identified and talked about. And if you came to our board, Scott, you'd hear us talking about the previous visits, which you may or may not have done. I suppose I'm talking to you as a member of staff now, Scott, because you are talking as a member of staff to us, as opposed to your research governor bit. And that is, it's a two-way conversation. And we absolutely do feedback in a way that is, this is what we think we heard, this is what we said we'd do, this is what we asked you to think more about. And I'd like you to go back to your team and say, why aren't we all hearing this then? Why can't we all check that out? Because it's definitely going back to the teams. I can ask that question as well. Where does that go when we send it back to you? Because we've got to have a point of contact. So, and we may think more about on the board visits, doing that as a summary at the end as well. We could perhaps do that. I think this is what we heard, and perhaps, but it's two-way, Scott. It's always got to be two-way. And if you're not feeling heard, it's great to say that at the time and discuss it in your teams. And if you're not discussing it in your teams, ask the question why.
Okay, Scott, but we'll pick up some of your conversations. I think it'd be useful to have a chat outside the meeting anyway, Scott, in terms of we're open to whatever we can improve. Okay, thank you. Billy, you've been patiently waiting. Thank you.
No, it's all right. It was interesting. What I particularly wanted to say, Heather, was that it was pretty impressive, the sort of range of voices you heard in seeking your assurance to be able to say definitely, yes, things are getting better. And you seem to have sort of done quite a lot of listening to people. But I didn't hear you at any point mention that you'd listened to friends and family of the people on the wards. And, you know, kind of like friends and family can bring a whole new objectivity to reality or how they perceive the standard and quality of care that perhaps might really help you reach that understanding better. I don't know if you wanted to comment on that.
Yeah, absolutely. I totally agree. I perhaps did a short term. I used a shortened language for it, Billy. I'm sorry. I think I said service user and carer feedback, but in that, the friends and family test is definitely there, and that's part of it. I'm sure we can do more. But it's, and you know, we're getting much better information these days from the complaint system. You know, so and lessons learned and all that's much better than it was. But yes, I agree with you, and that is certainly on the list of feedback loops that we can look at.
But did you actually, on these visits, get to speak to any of the families and friends of the people on the ward?
Oh, right. Sorry. No. So you're right. And when we do a board visit, then no, we're speaking to the people who are there, not the people who aren't there. I'm not quite sure about the new culture and quality visits, actually, just because I'm just not familiar with the list of what they gather evidence from, but they may well have that as part of what they put into that. They probably do, actually. I would think it makes sense. Yeah. So, yeah, so that would be happening, not the board visit blob, but the blob that said culture and quality visits. That would be in there.
Okay, thank you.
Thanks, Billy. Mark?
Just unmuting myself. Right. A couple of things. First of all, like Scott, I was a bit concerned, Heather, when you sort of kicked off and said we're going to focus on the presentation was going to focus on the journey back to good with regard to CQC. But actually, I then thought, it made me think, and I sort of thought, well, this external agency that's responsible for looking at quality has identified a number of things that we have to address. And I think it's quite right to focus on saying this is what we're doing, because in some senses, unless the organisation can demonstrate that it has addressed those, it is much harder to then say, from a point of view that autonomously as a Sheffield-based organisation, we're now also going to be looking at these things, because constantly the organisation will be pulled back for the CQC rating, and of course that affects how the trust is perceived within the city and externally. So I think, although I was initially concerned, I thought, yeah, I can see the logic of that. And actually, that isn't to say that other work isn't going on. But if we can get through this period, the trust has bought itself valuable space to be saying, right, now we can really focus with confidence, because we've addressed the things that have been flagged up by the statutory regulator, with confidence to really then be better than good, and which is the stuff that the regulator by and large is less. I'm not saying they're not concerned about it, but is less concerned about. So, frankly, as I say, it made me think, and I welcome the approach. Just to say, with regard to the voice of people who are using the service, including carers and friends. I mean, as I said, I was heartened by the discussion I had prior to this meeting in the workshop with regard to engagement and experience. I think this organisation is no different to any other. There's a range of mechanisms. I mean, you mentioned friends and family tests, which I'm not a fan of, but care opinion based in the city, I know the trust uses and is developing its relationship with, and I can remember James Monroe coming and speaking at a governor's meeting some time ago. And I think that starting to really dig in and get more personal stories is really strong. I would flag up a conflict of interest at this point, Chair, because as the chair of Citizens Advice Sheffield, we provide the advocacy service in the city. And I know recently, Jan, that you've had a meeting with our new chief executive. And advocacy in itself and the activity that comes from advocacy is also a really important, just one of the really important indicators that I'm sure the trust is using when it to get a feeling and make sure that it has a handle on people's experience and quality of services. Thank you.
Thanks, Mark. That's really helpful. It is. I was just reflecting on your comments, Mark. I just wondered, Mike Hunter, the medical director, is leading on a quality improvement work in the trust, isn't he, Jan? And I mean, I know it's not all down to Mike, but he's the executive, if you like, that's got it under him. And I did wonder, I'll have a word with Mike and just see when would be a good time. But it might be a nice development session for the governors to have some sort of, interaction with some of the quality improvement work that's going on in the trust as well, because that will be far wider than just the CQC. Jan?
I was just going to add to that. Firstly, as a board, we often talk about, and we're very clear, that the Back to Good priority isn't about the CQC compliance, but it is a key component at the heart of it in the way that Mark has just described. But it is much wider, which is why things like the quality improvement work, the work that Sally Midgley is leading on around service user experience, and embedding that across the organisation so we get a greater voice. All of those things are absolutely critical to our continuous improvement and showing and telling and building on our strengths in other areas. I just wondered if, building on what you just said, Sharon, it might be useful to come along and talk about the range of ways that we look at the level of quality of our services and whether how we look at it more broadly as well. Because I do think it's really important that our governors know whether we're on that path of compliance back to good, because that's your basics. And we are using those to look at other services that don't happen to have been looked at. We had a deep dive review, whatever you want to call it, into our community services again for all the reasons that you just alluded to, Scott. Just to have another look at where we can accelerate change and support people to move forward in the areas that people are very, very concerned about, and quite rightly, as are our board. And we've got another session on our recovery services at our board next time, haven't we? Explicitly asked for by the board. So I'm just wondering if people like Mike and Beverly and Sally could pull that together with Heather perhaps, and think about how we might share that as a bit of a spotlight.
I think it's a good idea, Jan. Thank you. Building on yes, you're right. It's more than the quality improvement. I think that if the governors are in agreement with that, is there support for that from the governors? Yeah, I think that would be a really good session, actually. And so, Heather, I'll work with you on it, but could you we work with exec colleagues to pull something together for a governor meeting, and then depending on how much time we need, we can build in a development session for it if we think that, rather than just try and cram it into a full council of governors. I'd like to do justice to it if we're doing it.
Yeah, and I think that's a really good idea, and I think also it's an indication of where we are now in terms of our sort of development. I think the reason that the Council of Governors wanted almost the kind of report on compliance with CQC was because when we had the really awful report the first time around, it was, well, what are you doing to address all of these issues? So it was almost that imperative to sort of say how we're getting out of that. But now we're in a position where we can sort of talk more widely about, or the breadth of that and the ambition that is around that. And so, yes, I think I'd be very happy to facilitate that sort of discussion.
Thanks, great. Scott?
Yeah, it's really welcome. It's really welcome. Absolutely. But can I sort of push us a little bit further? So I don't know quite the right terms, but I've heard of other trusts where they take a sort of area and they do like a day long sort of, either they call it check and challenge or something like that. And so what I want us to avoid, it's obviously great that this will be NED led. That's fantastic. It'll obviously be exec informed, but can we do something where we formally build in challenge instead of kind of, we're kind of come to these meetings and we're seeking assurance, and very often we're kind of told all the good things, and that's great, and then asked to kind of nod and believe them. Can we have almost a kind of, I'm not saying adversarial, but something where a kind of contrary point of view is put, so we really stress test what we're hearing? Is that possible? Could we build that in?
Let's give it some thought, Scott, because it can't be like a confirm and challenge meeting. It can't be a performance meeting, because that's not appropriate to the role of governor. But
around assurance, though, around assurance.
Well, as long as it's appropriate to the governor, why don't we explore that and see what that could look like appropriate to the governor role? Because, as I say, I don't want it to turn it into some sort of performance review or, confirm and challenge meeting, because that's not what it was intended to be, and that's not appropriate for the role of governor either. But if we could work with it in the context of the appropriateness for the governor in terms of being able to ask questions and challenge, etc. Let's have a think about that in terms of, but making it appropriate, because, as I say, I'm very careful. There is a line between what is appropriate and what isn't. But happy to explore that. But as I say, my caveat is that it's got to be appropriate for a governor role. But yes, we can do that. Okay. Thank you very much. Right, that's great. Well, it's been a really useful questions and debate, because it's led to that outcome that we will take as an outcome to do that. And I think that'll be a really good session. And we'll work with Scott and others to find, sort of finesse what that will look like and how that will work. So that's good. Thank you very much. So I'm failing drastically. We're running well behind, but it's because of good debate and good questions. So thank you for those. If we can move to item 10, Richard. Richard, due to time, can you be succinct if you wouldn't mind, and then we can take questions and comments, please. I think you must be on mute, Richard.
Sorry. Yeah, I was just going to share the slide deck very quickly, if that's working, which it looks like it isn't. Oh, yes, it is. Let's see how that goes. Oh, no, I think we have a problem. Let's see. Oh, no, there it is. Okay. If you can see that. Oh, I think we're the wrong one. Right, let's not bother with that.
We have all got them, Richard, in the pack.
Yeah, so for the sake of time, let's not do that then. So hopefully I can take that off. Failing to take it off. How do we do that? Sorry about this. I'm struggling to take it off share. No.
Amber or Frankie, could you help Richard if you're able to, please?
Sorry, I've got it up and I can't. Oh, stop presenting. Got it. I think. There we go. Yep.
Well done.
So sorry about that. We'll get slicker next time. In a nutshell, why are we replacing Insight is the key to this. It's crucial that we have an effective electronic patient record. We've been using Insight for the last 17 years. It's aging technology. It's not as stable as it should be by a very long way, and we have to put a lot of effort into keeping it going. So for many years now, the Trust has been trying to procure a replacement system. There have been a number of setbacks, some well outside our control, but I'm very pleased to say that, as you know, we've now got to the point where we have successfully tendered for a replacement. The slides describe, in a sense, the complexity before that we have and how the new system will be integrated, and should be a great deal better for both for staff and indeed for users. So the slides outline the process that we went through. It's been overseen by a lot of governance within the organisation, and that will continue. The Finance Committee will continue to keep an eye on this as it goes forward. Basically, and really just to summarise, there will be significant benefits to it in terms of reducing the paper, reducing all these awkward workarounds that staff have to do. There'll be more efficient processes, and it will release benefits. It's a big task of work to do. If anyone who's been involved in these things knows that there are many issues. It won't all go smoothly, unfortunately, but we're going to do our very best, and we're going to try and do it as quickly as possible. And I think we're all delighted that it's Rio, and the company we're using is Sheffield based, so it's a double win for Sheffield. So thank you very much, and apologies again for my rubbish IT skills there.
Don't worry, Richard, your skills are still ahead of mine, so don't worry about that. So thank you very much. Adam, you're the first question.
Thanks, Chef. Thanks, Richard. Mine's regarding on when we do when it's all up and running, and it gets to the end stage, shall we say. Is it going to be like a test space where staff and public service users can make sure that it's clinically suitable? So put it in that way terms, in layman's terms, because as you said, Richard, the health system is quite confusing. But again, it's when we design all these, like when I teach at the university, I say, can we also look at making sure some of the reporting one is in plain English and not what we call a medical jargon.
Okay, just quickly respond to that. There's been a lot of work has been done over the last year engaging with service users, staff users and others, and I think there's been much more engagement than there's ever been. So I think we've ended up with a specification that's better than it's ever been, and we've certainly involved key people in the assessments. There have been whole day processes around looking and checking that the system's going to do what we want. I mean, this is an off-the-shelf system with modifications, so there's always some stuff we would like that we're not getting in the product, but it's certainly leagues ahead of what we've got now. The implementation takes us into next year, as you might imagine, despite Jan in particular has pushed as hard, I think, as we can to try to get it in as quickly as possible. there are stages along the process, and clearly there will be stages before we actually go live with it and staff being involved and so on. So we can let you have more detail on the key dates. I'm sure that will be useful to have because it's not in the presentation.
Okay, Adam, thanks for that. It's a good point. So just as an action, we'll take that we will just send an email around with key dates, just so that people are aware of the key dates. We'll do that. Thank you.
So it's not just that though, but when we are looking at systems, you also, it's okay having it from the staff point of view, but you also got to have service users point of view as well.
Yeah.
Because they can actually, when letters are going out or not so are going out, that people then can actually understand it, because I'm getting feedback from ones that saying that when they are having medical appointments, you can't actually understand it.
And that's one of the benefits of the system. It allows better integration with some of the external systems and getting some of the stuff in and out of the system, whereas which is harder to do at the moment. So I think there's plenty of scope there.
I think Adam's points. Adam, forgive me. Is your point is that, for example, when we're writing the letters, it's in a language that people don't understand.
Oh,
Okay.
I see. Okay, I can't really speak to that.
Adam, can we come back to you on that, because I don't know the answer, and I don't know if we're doing any work on it or whether we're not. Is it any specific area?
No, it's not. But it'd be good to have a conversation with either Jan or someone outside this one to lay my concerns, because it's what I'm hearing.
Well, I can certainly arrange for that. We can certainly liaise with the patient experience team to receive that feedback, and then we can take it forward. Leave that with me, Adam. I'll have a conversation and see who we can get that feedback to, because it is an important point that people need to be able to understand the letters that we're writing to them. It is really important. So I'll work with you on that, Adam, to make sure that we enable you to give you feedback, and then find out if we're doing anything, or if we can do anything about that, and whether it's specific areas or whether it's a general point. But we'll have a look at that, because it is an important point, so I don't want to lose it. So Cecilia?
Okay, hi. I was just, having been a manager seeking to implement something similar in a previous life, I'm just wondering what kind of mitigations you've put in place with regards to loss of productivity in people learning the new systems and processes and actually being effective in using them. I know long term all the benefits, that you're going to get in the long term, but in the short to medium term, what mitigations are you going to need to put in place to receive the hit? Because you're definitely gonna get a hit. You might even get a hit with people leaving because of their difficulty in using the new systems and processes, no matter how good they are.
Just to say, I think we've tried to build on Rio's a system that has been implemented in a lot of organisations now. So we tried to build on the learning from other places about how to effectively get that to work. We've allowed key staff time to input into the process so far, and I do believe that the implementation phases, take that into account as far as we can. But you have to be realistic. There are limits to what can be done. When we've highlighted our issues over staff, recruiting staff and recruiting extra numbers of staff. So we will have extra staff working on this project from outside the organisation who help in terms of all the technical side of it. But, we're going to have to take all what you've said into account in planning it. But I would hope that, it's actually going to demonstrate its benefits very quickly, rather than being something that staff are going to be frustrated with, which certainly has been the case in some system implementations. You're absolutely right, and we can probably share notes on those.
Okay, thank you, Rich and Cecilia. Jonathan?
Hello, sorry, I will be as quick as possible.
All right, Jonathan, don't worry.
Looks like a big system. Good luck with that. I'm looking at the aspirations aspect, and it might be something that we've not thought about. A lot of them really good, like wearables, things like that. The one that jumps out at me is the artificial intelligence bit. Let's stick a buzzword in, make it look good, but we have to be really careful around artificial intelligence in that if it's trained in the wrong way, it in itself can give results that are biased, which obviously can have an effect on service users through perpetuating stigmatization and such. So it would be something that I would approach quite delicately.
Yeah, I think maybe can I emphasize, I think this procurement, this system replacement is absolutely about getting us a robust, sustainable platform which has got the potential to overcome, well, which will overcome many of the difficulties we have with the current system. So it will do that. Then, because of the way because it's a much more up-to-date system, the way it's written, it then has the potential to do some of the stuff that may come in over the next decade. So we're not going to be doing, clever AI stuff at the beginning of this project. That is something, if those technologies mature, this system's more likely to have the ability to connect and to utilize those. What we know is our current systems, are in computer terms back in the arc, so they don't have the potential to do anything. So some of those aspirational things are around where we could go, but absolutely the focus for the next 18 months is on getting this system implemented robustly so that it delivers the immediate benefits we need. And be clear, we are on a burning platform and we need to replace Insight. It's gone on for far too long, so we must do that and get that right first. But yeah, it's, there are big issues around lots of these aspirational things that you hear about, and I'm sure you're well aware of that. And data governance in the NHS is very, very tight. So, we're not going to be doing some of this stuff anytime soon.
Yeah, thanks for that. It was just to bring it up because a lot of this you have to think about now, not in 10 years' time, because if you're learning on a system, if this system's populated, it's been working brilliant for 10 years, you chuck AI on it, then you're looking about how practitioners have written about patients, the keywords, things like that. It's based on past usage. So you have to approach it now, even though it's an aspiration.
And it's just I know our team, it's one of the criteria we used in looking at the system to how flexible it was and how compatible and how it could develop.
Yeah, you wouldn't want another Facebook where people were being classified as animals, would we? So, yeah.
Thanks, Jonathan. Catherine, final one to you, and then we'll move on to the next item.
Thank you. Just a quick one. Now Rio's been agreed on as the new system, is there any further staff consultations planned specifically in relation to both the capacity and the limitations of Rio?
That's a good question. I don't know the answer to it, so I think we should find that out. I think, as I said, there's no perfect system. One of the reasons why we have taken so long is that we had a period where we tried to design our own system and that wasn't that proved very difficult. So there are strengths and weaknesses of everyone, but yeah, my assumption is that those things are built in, but I can't tell you what they are right now. So I'm sure they're in the business case, which I haven't.
I think Richard, I think Jan's got a hand. Jan's got a hand up.
Yeah, I just wondered what you meant by a consultation, Catherine.
Well, because although I'm aware there's been lots of consultation in the lead up to the tendering process, then I was interested to, now we've got a specific system to work with, if there's going to be further consultation with clinical teams as to kind of what they'd like to see in it, what needs to be in there.
Okay.
So what doesn't need to be in there.
we're using consultation with a small c, aren't we? So
Yes.
there's got to be a massive, there'll be a planned engagement and involvement programme alongside the rollout. I've rolled out Rio 2 or 3 times actually in my lifetime, along with other things. And it's the same principle for whichever thing you roll out. Whichever service it is that's next on the list, sort of, they will be writing their own scripts around certain things in terms of things like for letters, all sorts of bits and pieces. We will be supporting those areas with trainers and, for want of a better phrase, coaches to walk alongside staff while they write some of those things. So it will require, as we roll out to each service, a real detailed engagement and involvement programme, and that's why it's taking so long to roll out, so that that's done safely and effectively. So yes is the answer.
Great, yeah, thanks, Jan. That's reassuring.
That's great. Thank you very much. Good question. So if we could move on, please, to item 11. Pat, sorry for keeping you waiting. Welcome to the Council of Governors and congratulations on your substantive appointment. We did mention that earlier. So if we could be succinct and over to you, Pat, please.
Right. Thank you very much, Chair, and thank you for those thanks, everyone. It's really good to be here, and I wanted to take up the substantive post, apply for it, because everybody's been so friendly and helpful here. So just wanted to give you all that feedback. Thank you. So what we have here is a summary in terms of how we're progressing with the new headquarters arrangements for Leaving Fulwood project. So you may be aware that at the end of last year we concluded the sale of the Fulwood site and the phased. It happens in phases, and therefore we have this year to move off the site whilst there is some further detailed planning happening through being driven by the purchaser of the site. So our plans are to move off the site, to relocate to the new accommodation, which is set out in these slides, by the end of June. However, that's not a hard date. We have some flexibility around that. So I just wanted to make that clear, that that we don't need to have too much anxiety around the end of June, but that is the plan that we're taking forward. We've done quite a lot of consultation in terms of group consultation on the sites, and the 2 sites that we're moving to, the 2 buildings on the same site, are on the second slide there, Centre Court and Distington House, and so you can see those there. We are also making arrangements to have some flexible access to some space in the centre of Sheffield for meetings or for some training events. So it's not all solely based on this as an alternative. And I've included some of the feedback that we had around the group consultation, which brought us to the point of focusing on this particular site. And we're doing a lot of work around transformation as well as relocation. So I just wanted to make that point. And so I'll leave it there. Thanks.
Thank you. And Pat, I think one thing is just to pick up that this is tied in with the green plan and sustainability work, isn't it, as well?
It is, absolutely, yes. Yeah.
Thank you. Any questions for Pat? No, I think you've all you've probably followed this for far longer than I have. So yes, thank you very much for that update, Pat. So if we could stay with you, please, and move to item 12, which is the planning guidance and priorities.
Yes, thank you very much. So the priorities and planning guidance for the NHS came out on Christmas Eve, and so we've had a look at this in terms of a number of our executive meetings and subcommittees. So what we have here is a summary in these slides. It identifies the 10 priority areas, which include services for people who have a mental health issue, learning disability or autism, as we would expect. And also the link with urgent and emergency care and primary care. It talks about the key messages around capacity and resilience, so a really big focus on workforce. And you were talking about workforce earlier on, and it's an issue for all organisations. It's a really big focus for the NHS and all organisations in the NHS. So capacity and resilience, and then partnerships and relationships. And it talks on the key messages slide 2 about the 4 strategic purposes of the integrated care system. And we know that also the Integrated Care Board, the statutory body in the new arrangements, is going to be delayed until the 1st of July. So that's quite important for us in terms of our relationships and partnerships more locally. And it does also say that we will have a rolling plan which will commence in March 2023. So we're linking our plans in with that sort of time frame. It then goes through some of the financial arrangements, and we're still working that through with the integrated care system, because there's a new capitation formula, and we're looking to understand what that means for us. It may mean that some integrated care systems have more funds and some have less. So it's really important for us to keep an eye on that. And so that's what our Director of Finance is working through at the moment. And then it talks about the importance of workforce, digital development, and then expanding mental health services and services for people who have a learning disability. And that's really important for us with our transformation programme around learning disability as well. So I'll leave it there. Happy to take any questions. Thanks.
Thanks, Pat. Any questions for Pat? No. Thank you very much for that update, Pat. That's really useful. So if we can move on to item 13, which is the place report. And again, I know it's quite a comprehensive report. If you just pull out some salient points, that'd be useful. Thank you.
Yeah, conscious of time, so I've cut down what I was going to say. So for those of you that haven't been around for a long time, you may not remember that place assessments, the patient-led assessment of the clinical environment, something that took place every year and enabled us to look at comparators with other organisations elsewhere that are similar to us. And it's the non-clinical aspects of the environment these place assessments look at. We were asked to do, the national ask was to do a place light assessment last year. So it didn't involve the range of people that you'd normally have. For example, Health Watch would be there as well. You'd perhaps be able to go and sit and watch people and have meals with people, that sort of thing. We weren't able to do that this time, but there were staff and patient assessors that took place. There will be a place light report coming through around cleanliness, dementia and disabled access. And that's working through the Quality Assurance Committee, I think in the next month or so, then through to board in April, May, and then through to COG, presumably like this one, later on in the spring and summer. The background to this really is, in terms of this report, is that there's other information that's come through the physical health audit that was also done last year, and that had something about we didn't have a healthy eating or healthy lifestyles strategy, and also nationally let's get the right name of it, the review of NHS hospital food gave a lot of reasons why food and the nutrition and hydration of patients perhaps hadn't been the focus of many organisations over a number of years. Patients aren't well, people have medical conditions, religious requests, cultural preferences. Some patients need help to eat. Hospitals are busy places, kitchens are often a long way away. You need to regenerate food locally. Food can sometimes not be seen as a priority, and you can see all of those aspects in the areas that we've picked out in this report, and it's quite a well written report and it's in front of you here today. Just talking with the teams that are involved with this, it's very clear that we've got a way to go yet. We've had some work done since the place report was undertaken during the summer. The nutrition and hydration steering groups leading the work on this, and there we've got the dietitians, the catering managers, OTs working together closely to adjust menus, to listen to people, make sure we've got proper ways of listening to what's going on the wards. We have, I think, weekly meetings on most of the wards where comments are raised about the environment, including food, and they need to make sure that that information feeds regularly and reliably through, so that those that are involved in sorting out menus and the catering arrangements listen and are able to hear what's going ahead. Going forward, there's work on developing KPIs around food, and that'll be as part of the KPIs for the estates function that will come through on the IPQR and through to the board. I mentioned about the cleanliness, disabled access and provision for people that have got dementia.
that information, as I said, will come through in the next few weeks. But in the board report that went to January board, we touched on that, but we particularly touched across the piece really at the board around the importance of sustainability in healthy eating and exercise, looking at the feasibility of buying local, because that was in that report, the fact that we should have a new and an ambitious food strategy. The board wants to see updates on a regular basis, probably come through the KPIs, but there'll be other updates I'm sure coming through. And I think probably that's a very quick canter through, Chair, of the points I'd raised. Apologies if it sounded a bit disjointed. I had to cross a lot of bits out while I was doing that. So I'll stop there and just see if anybody's got any questions. And Pat, I think, will also help me out if there's anything particularly complicated. Thank you, Pat, in advance.
No, thank you for that, and it is quite a comprehensive report as well. So thank you for the introduction and the report. Adam.
Thanks, Chair. It's really to build on what Anne was saying, because I've actually been involved with the patient-led assessments quite a few times, and to give it context, on that one is very interesting way of doing it, but it's a bit like the 15 steps as well. But my overall question is on it is, when we get the feedback, can we make sure that not just the staff get the feedback on it, can we make sure that some of the service users get the feedback? Because a lot of time, when I've done it, it's always been the senior managers on the wards that will get the feedback. But it's not. But I've never seen any of the feedback that feels like the ward meetings, how the places has actually gone.
I mean, it's a very good point, Adam. I was just thinking about how useful these community meetings that are held on each ward could be, because if it's the route of picking up the issues, it should be the route of feeding back, shouldn't it? Obviously, there'll be team briefing and other arrangements to get it back formally through to staff and the teams and the housekeepers on the wards that are actually doing this stuff for us. But
we normally do it after the visit. Sometimes we have a mini debrief with the staff, but I've never heard of it actually. When done it, if it's ever gone back to a ward meeting with patients or service you, and it's just a way of getting that new approach, that two-way dialogue.
Yeah. Well, the route's there, isn't it? So we should just use it. Totally agree.
Thank you.
Yeah, we'll take that forward and make sure that's passed on, Adam. Good suggestion. Thank you. Okay, thank you very much. We can move on to item 14, which is NED recruitment and succession planning. This is just an update. Billy, I think you also wanted to say anything, but Terry, do you want me to start or do you want to start? Just an update for the council?
I'm happy for you to start, yeah.
Okay, well, in a nutshell, as the council is aware, we were planning to do a NED recruitment to replace Sandy, who left obviously at the end of last year. And at the last Council of Governors, we did mention that we were succession planning for Richard, who will be not a fixed date, but probably leaving towards the end of November of this year. So with the nominations committee have been working really hard with us. And we should have gone live actually this week for recruitment of 2 non-executive directors, and we will succession plan for Richard. So we'll work with that person coming in at a time. And we are looking for somebody who understands good quality and also someone with probably financial and commercial acumen, both with quite experienced, because as we've reflected in the meeting today, we really do need some experienced non-execs to help us on our journey. We can share the link with you all, because if you could circulate that amongst your contacts and people that you know that might meet the criteria, we'd be very grateful. And I'd like to thank the nominations committee and Anne, who also is supporting that. It is quite a time-consuming job to do this, we're involving Gatenby Sanderson as recruitment consultants, but we're really quite excited about it. It's a really good opportunity for us. And so I'll just hand over to Terry or others on the committee if there's anything you'd like to add.
I think that was pretty comprehensive, thank you. I think the plan is to do the long listing and short listing in March. and then the interviews I think were meant to be scheduled around the end of March, but I'm not sure. Is that got a little bit later?
I think it has. I think we will probably be looking to, because of Easter, delaying quite a few things. I think we'll be looking to appoint, if we're successful, at the very beginning of May, and we will need an extraordinary Council of Governors to take a vote on appointing if we're successful in getting the right candidates. So we're just finalising the timelines, Terry. I think you're right. Around people's diaries and also Easter and everything else. But we will send that out to everybody when we know when it is, because we'll also be requesting whether any of the governors would like to join the stakeholder panel as well as that. So that would be really good if we could just get a couple of volunteers at least to join that stakeholder panel. And then ultimately, the interview panel will make a decision based on feedback from elsewhere, and we'll put a recommendation to the full Council of Governors, which, as I say, I think with the timing we'll need a little extraordinary meeting just to do that, but we'll get that in your diaries as soon as possible to make sure that we have enough people there to make a decision. But as I say, thanks in advance to the Nominations Committee, because it's really important work and it does involve quite a bit of their time. But also the Nominations Committee, Billy made a good suggestion at our last meeting. They'd like to come to the next Council of Governors to talk about the work of the committee and also why they're on it, to encourage perhaps some new governors to, or not necessarily new, but different governors to come and join them on that committee and support the work of that committee. Is there anything you want to add, Billy? No. Are you on mute, Billy, or is that okay? Okay. If we can move on then to item. Sorry, Billy.
There's just one thing I wanted to. Oh, sorry.
Go ahead.
Just took ages to get unmuted. There was just something I wanted to say, that we have to take that with a little bit of caution about recruiting new governors onto the NRC, which would just be fantastic. But most governors, or a huge number of us, by the time this actually happens, will be up for re-election or may decide not to stand. Perhaps it might be better to wait until the new intake is embedded.
Yeah, we could do, but if anybody in the meantime wants to at least shadow the committee, they could do. But yes, that's probably wise. We could do that afterwards. We get the new. You're probably right, Billy, with timing. Perhaps we should bring a little presentation to the Council of Governors after we've had the elections, so that you're getting a full new audience. Yes, that's probably a good suggestion, Billy. We'll move that to the meeting that follows the elections. Okay. Thank you all very much for that. So if we can move to item 15, I think Tanya, sorry to keep you waiting, Tanya, I think you've joined us to talk about the quality objectives.
I have indeed. Thank you, Chair. I know we're running behind and I will try and be as succinct as I possibly can. Hopefully the council will have received the presentation. I wasn't planning on going through that sort of slide by slide. What I'd like to sort of give as an overview, if I may, is to say that I'm hoping that the presentation provides you with assurance on the delivery of year one of our quality objectives. Year one was focused basically around sort of systematically capturing and analysing the data in relation to sort of our equality and inclusion in access, care and treatments. And the first year was to basically use that to enable us to set the baselines for improvements going forwards in year two and year three. For members that have been here sort of last year, you will know that we agreed to set objectives that were a 3-year time span to make sure we had more of a sort of focused view. So we've just come out, or we're just coming out of year one of those 3 yearly objectives, and we're moving into year 2 and year 3. And as I said, we now need to focus on, we've now collated our data. The final quarter of the year that we're in now is about analysing the data, really understanding what that's telling us, and then utilising that data to enable us to set the targets, what improvements we want to see for year 2. And then during the year in year 2, we'll be upping those targets to understand what we want to be setting for year 3. So the presentation hopefully explains that for you. Again, governors will understand and that it's part of what we want to come and consult with you to make sure that we're still heading in the right direction of what you see are our priority areas.
I'm not, because we agreed last year we would set 3 yearly objectives. I'm not particularly asking if you think that they're still the right priorities. What I would just like us to think about is whether we are heading in the right direction, that we do still think that they are key, and if there's anything specific that that you don't think we're already targeting, that we are able to sort of target that as we move forward into year 2. So what we're looking at going forwards is to, as I said, to start working towards really understanding what the data is that we've collated this year, setting that, using that data to set our targets, and then starting to work towards those targets about reducing the barriers to services with regards to people from a sort of black and minority ethnic background, and understanding why those barriers are there and what we can do to reduce that. Again, on the same vein, to make sure that we're improving the equality and restrictive practice. Governors will know we're working hard to reduce the amount of restrictive practice that we use as an organisation. But when we reduce that, is it being reduced equally, if you like, amongst our service user groups? And then the final one is with regards to continuing, if you like, to implement our co-production. We are writing and developing our service user engagement and co-production strategy, and again that will build on what we're trying to do within our quality objectives and to strengthen how we work across third sector organisations, which again is key for us understanding and developing those further. I'll pause there, Chair, if that's okay, and ask if there's any particular questions or if there's any particular bits that people want more information on, if that's okay.
Thanks, Tanya, that's great. Any comments for Tanya? Does it feel right to you? Do you feel like we're on the right lines? I think lots of nods there, Tanya. I think we've actually throughout the meeting we've picked up on some of these things, haven't we? Like access to services and restraint and seclusion. A lot of it's been, which just show how relevant it is. A lot of it's been picked up in the actual meeting itself and the discussion. Is there anything else that you'd like to pass on to Tanya? Well, comfortable with this direction and where we're going to? Yeah, I think so, Tanya. Is there anything else you need from the governors, Tanya? I know we're actively involving them in, some of the, like, for example, the strategy development and things like that. Is there anything else you need for today?
No, that's absolutely fantastic. Thank you all very much, and thank you for having me here.
And thank you. And it was really good slides, very clear, Tanya, about what you're aiming for and what you've achieved. So well done for that. That's really good. Thank you very much.
Thank you.
Thank you for joining us. So if we can move on to item 16, the last item, this is actually for Susan, particularly who's written this, to be fair. So Susan, this is really for information, isn't it? An update to explain where we're at.
Yeah, exactly that. Thank you, Chair. It's an information paper, be really brief, but it's about the work we're going to do in line with guidance that's been issued by NHSIE, which outlines a new approach to the non-executive director champion roles. Over the years, the number of issues that non-executive directors are being asked to deal with has been increasing, making it difficult for NEDs to actually discharge the roles, and this review is actually really very welcome. So the NHSIE recommended a small number of roles to remain at board level, which requires individuals to drive forwards, but then also to align other issues to the board subcommittees that the board already has in place. And the tables in the report outline where these may well sit. So it's the advantage that actually the issues rest with committees rather than individuals, and then we need to have the reporting through to the board. So I've outlined the next steps, which is actually to review the roles, complete the alignment, make sure that we update terms of reference for the committees and establish the reporting through to the board. Thank you.
Thank you, Susan. Any questions for Susan? Anne?
I just had a quick conversation by email with Susan about the fact that things like EDI aren't on the list. So she said to say it in the meeting to prompt her to say something else. This is a prompt to Susan.
That. So yes, so this we can be flexible because including in the guidance, it very much says there'll be other issues that we as a trust think we would like to have that oversight of, so we can include other areas because the approach is actually very strongly recommended, but it's not mandatory. So we'll make sure that we do include other areas. Thank you, Anne.
Thank you both. Good double act there. So I think this has really been brought to you because in the past there has been, as Susan said, a whole raft, a long list of non-exec champions and leads for various things, and it's really to explain that that's going to be very much simplified to a much smaller list. So that you understand which, and we'll populate it with which non-execs do which. I think you're probably aware, but we'll do that. But it is really just so that you understand the roles and responsibilities of some of the non-execs will change, and some of them will move to committees, which personally I think is a really good decision. Adam?
Thanks, Chair. Thanks for that quick and simple diagram, and Susan. And mine was, you say what that learning from the quality assurance one, looking at that one, learning from this, would that also be learning from the, for example, the leader program and things like that?
Yes, we can include all of that. I mean, you know, these are the suggestions in the guidance.
Because with that one, I know at the moment it sits with CQC, and it might end up at ICS level, but locally placed. I think
Absolutely
it'd be good
right. Yep, we will do that.
Thanks, Adam. I think that'll be captured in the quality committee terms of reference, Susan, but can we just check where it goes? That's fine. Thank you. Anne, is that an old hand or a new one? Old hand. Thank you very much. Okay, so any other business? I'm not aware of any. No, thank you. If I could just, before we close, just draw your attention, as I said, to the calendar, which is with your papers. If anybody needs a hard copy, let us know. If it gets too busy, we'll split it onto 2 sheets. But thanks to Amber for putting that together. We'll keep it up to date, and so that you can then see, you know, on 1 sheet all the dates we've got planned for the whole calendar year, rather than having to look through calendars, etc. So hopefully you'll find it useful, but any feedback is welcome. Can I thank you all for your contributions today, and everybody, for the non-execs and Jan and Pat and others that have all contributed. And thank you all for your contributions and your questions and debate. I think we've got some good outcomes from today. So have a good evening.